Everyone, I think we've got about 28 participants. It's great to have you here today. My name is Shabir Musa. This is a CPD program that's with AfroPHC, the African Forum for Primary Health Care, together with the Johannesburg Health District. We're really fortunate in having today Professor Yasmin Adam, who's a chief specialist and adjunct professor at the Department of Obstetrics and Gynecology, and also at Chris Hani Baragwanath Academic Hospital and the University of Witwatersrand in Johannesburg. So we're really great to have shares interests in contraception, as well as prevention of cervical cancer, stillbirths, and maternal morbidity. And she's going to talk to us about a topic that we often take too easily for granted. That's contraception. And it's titled Contraception, a Simple Guide. So thank you very much, Yasmin, for joining us today. Let me allow you to present. Are you able to share? If not, I'll just pull out your presentation.
Okay, I think it's easier for me if you share.
All right, I'll do that. I don't see a presentation. Did you send it in the last few minutes, eh?
Yeah.
Okay, I don't seem to see it. If you can, if you click on the green button, if you open it on your screen, and then click on the green share button, and you should be able to, because I've given you rights to do that. And then you should see it sort of on your screen as one of the windows or one of those in front of you. If you're still struggling, I think, let's just see if you can get it to me a second time. And I'll just send you a quick reminder email. But in the meanwhile, you can have some general discussion. Let me just see if I can send you something. Okay, I don't have an email from you. So,
yeah, I'm also not seeing it on my.
Yeah, let me just quickly send something once more. The email that I have, Yasmin, is yasminadam@gmail. Is that the one?
Yes, that's the one.
All right. I'll just send something quickly. You can just reply email to that and then see if you can send it. So I think we basically would like to just remind people about this CPD meeting. So Yasmin, you can open the screen. Do you think you can open the presentation and then click on the share screen, green screen? It's right in front, next to video, mute, etc.
Okay, let me try again.
No, have a shot, but open the presentation first.
Yeah, it is open.
Okay, if it's open, then you should see it if you click on that green button, which is on the bottom. As you scroll, sort of hover over the screen, you should pop up the share screen. If you click on that, then you should be able to open the presentation or share it. Not quite.
Still not.
Okay. Well,
and I put it on my desktop now, and I still am not able to send it. So let me resend.
I can speak to it as well. You can resend it if you can give it a second to send it again. And then meanwhile, can you show your video? Are you in a place where you're comfortable to show your video?
Yes, I am. Yeah, that's
all right.
fine.
And I think then just use it on your laptop, on your whatever you have, and just present it. And I'll try and work the.
Shabir, what's your email address?
Shabir@profmusa.com. Apologies to everyone for the delay, but I'm sure we'll find it very worthwhile.
Okay.
Okay. If you sent it, then just switch on your video and just present it, talking to it with the slides in front of you. And then I will try and work on the slides in the meanwhile.
Okay.
Yeah, okay, I think you just drop your screen slightly if possible so that we can see your face better. And I think that'll be much more engaging for everyone. Great. So you've got the slides in front of you, and I'll sort out the slides to see if I can share it while you're busy.
Okay, good.
Great.
So, welcome to everybody who's here. I'm going to talk about the WHO medical eligibility criteria, which is the Bible for contraception. The WHO does this medical eligibility criteria, and they answer certain questions that come up every 3 to 5 years. And then that gets used by countries. So this is the eligibility criteria by the WHO is written for programs, it's written for countries, and you as a practitioner could use it. And we would directly look at the WHO criteria. Then I'm going to talk about some examples on how to use the criteria. And I think HIV is still so topical, and contraception there is important. And I'm going to talk about some concerns there. Importantly, women have to be a part of the discussion for contraception, and then looking at counseling and what needs to go into counseling. And I'm not going to be able to go through all of those. And then once you've decided on a method, how you go about choosing that method. So, and then I'm going to end by just talking about some issues regarding emergency contraception. So the categories for the WHO is: 1 is where there's no restriction to the use of the method. 2 is where the advantages outweigh the risks. 3 is where the risks outweigh the advantages. And 4 is when there's an unacceptable risk to the contraceptive method used. So there's also another way of using this for particularly nurses that are prescribing contraceptives, and where they put 1 and 2 together and 3 and 4 together. So, and that makes it easier. So depending on where it is that you're using this method. Then what you would do is you always take a history and examine the patient, and then you would list all the medical conditions and then put them against every kind of contraceptive method, and then that will then give you a 1, 2, 3, 4 for that particular method in that particular scenario. I'm not able to move this forward.
What you do is just tell me next as you are switching your slides, and I'll move it along.
Okay, thank you. Next. Okay, so these are the listed possibilities. So age, whether the patient is postpartum or not, whether the patient is breastfeeding and postpartum, and that goes up to a year, whether there was puerperal sepsis, the risk of HIV, women living with HIV or women who are on ART, rape, post-ectopic pregnancy, migraine, STIs, liver disease, cardiovascular disease, dyslipidemia, superficial venous disorders, and of course, if you are using one of the inducers of the enzymes that metabolize drugs in the liver. So to take an example would be if you took a venous thrombosis or venous thromboembolism, and that would then be, you would put it against all of the types of contraceptives. If you put it against barrier methods, it would be a 1. If you put it against combined hormonal contraceptives, it would be a 4. If you put it against progestogen only contraceptives, it would be a 2 for some, and it would be a 3 for others. So those would be ways in which you would use that. Next slide, please. So this is an example of just being postpartum. So, and if you were postpartum and you had no other risks for venous thromboembolism, then any one of the combined hormonal contraceptives would be a 3 if it's less than 21 days. If it's less than 21 days since delivery, and there are other risk factors for venous thromboembolism, then it would be 4. So a risk factor would be if the patient is obese, that would be a risk factor. A family history of VTE would be a risk factor. If it's more than 21 days, so 21 days to 42 days with no other risk factors, it would be a 2 for combined hormonal contraceptives. And if it's between 21 and 42 days with risks for VTE, it would be a 3. And once it's more than 42 days after delivery, then the use of combined hormonal contraceptives is 1. So this is postpartum without breastfeeding. Now let's look at if there's breastfeeding. The next slide. So using another example with breastfeeding and postpartum, but using the levonorgestrel intrauterine device. If the patient is less than 48 hours postpartum, it's a 2. So you could put it in because the benefits outweigh the risks. Between 48 hours and 4 weeks, it's a 3. And in the South African guideline, we're saying that you can put it in at any time from delivery to postpartum to 6 weeks, and even thereafter if you need to. If it's more than 4 weeks postpartum, it's a 1. If there is a history of puerperal sepsis, then it would be a 4. So this has also changed over time, and that initially we were only putting it in before 48 hours, and the WHO eligibility criteria said that you then, if you were going to put it again, you need to put it in after 6 weeks. The ESHRI guidelines, which are the European guidelines, were the ones who came up first with saying that you can put it in at any time up to 6 weeks. So this is the way you would take every type of contraceptive and put it against every condition, and that would give you categorize the score, and then you could then decide whether to use that contraceptive method or not. So for example, if you have a patient who is diabetic and is on a progestogen only contraceptive, and you need to change that because she's having severe bleeding and you're unable to look after her bleeding, then it would be a 3 to put her on a combined oral contraceptive, but it would be possible. So this is a guideline. At the end of the day, you have to look at the condition, look at the patient, and decide whether you can use the contraceptive or not. Next slide, please. So this is then for some conditions where the method will not affect the medical condition. We wouldn't give it a category, we wouldn't give it a score. So these are conditions. So fertility awareness, which is either the calendar method or it's symptom-based, coitus interruptus, lactational amenorrhea, or sterilization, whether it's male or female. It would be something where you accept, or whether there would be a caution, or whether you need to delay it, or the S is for special, where the procedure needs to be done in a specialized service. So an example would be if you wanted to use fertility awareness and you wanted to use either the calendar method or symptom-based method, then it would be a D for delay if it was immediately postpartum, because you don't have a period, so you can't use that. Others, if you had a really young patient who said she wanted to be sterilized and it is her right to be sterilized, then that would be a C, because it would say that you need to caution that person. An example of a procedure that needs to be done in a specialized center would be somebody who had TB. So if the person had TB in the chest, then you would need to, that would be okay, and that sterilization could be done anyway. But if the patient had pelvic TB, then that would need to be done in a specialized center. Next slide, please. I can't talk to you. So if the next thing is, if there are women at risk of having TB, getting HIV, or women living with HIV, it's important to consider acquisition in somebody who is at risk. And then you, if that woman is at risk, then you need to think about whether the use of hormonal contraceptives will increase her risk of acquisition. So I just want to say one thing is that the algorithms for assessing risk of whether you're at risk for STIs or HIV is they do not predict those women very well. And there are different algorithms. And there are some who would predict 11% of women who actually then do acquire an STI or an HIV infection. So those ones are really difficult. But in a patient, if you consider acquisition, there were in total 22 prospective observational studies which looked at this, and 7 of the studies looked at combined oral contraceptives, and it showed no effect on HIV acquisition. There was one Kenyan study who showed a risk of infection, and that was really high risk women, and it was sex workers who were included in that study. So we're not sure about what to, so at the end of the day, in a patient, or in a woman rather, who is at risk for STIs, you could still use the combined oral contraceptives. Looking at northisterone and Depo-Provera, there were 6 studies in the one and 5 studies in the second one, which showed no effect. The one in the northisterone did show an effect, and there were 3 for Depo-Provera who showed an effect, and out of the 3, 1 was dependent on the model that they used, the statistical model. So at the end of this, the medical eligibility criteria for HIV acquisition says that you need to counsel women to say that none of the methods will prevent HIV acquisition except barrier methods, but that the studies that show this are really poor. That they were not good studies at all. In terms of the risk of progression, there were 7 observational studies which showed no association with combined oral contraceptives, and 1 RCT which did show an increase, but this was a trend. It wasn't statistically significant. And these studies were done prior to the way we use antiretrovirals today. So they looked at the change in CD4 count. They looked at when you would start antiretroviral treatment, and when you progressed from WHO categories 1 to 2 to 3 or 4. And then the question about transmission to the male partner, and again, very little, very poor information, but 2 prospective studies with combined hormonal contraceptives and 2 with progestogen only injections showed no effect. So looking at indirect studies for measuring viral load, they found no difference with hormonal contraceptives on plasma viral load. It's very difficult to look at studies which look at vaginal viral load and whether you can use these to look at transmission to a male partner. Next slide, please. So this is taken verbatim from the medical eligibility criteria, and it says that the voluntary use of contraception by women is critical for upholding their reproductive rights. All women have the right to evidence-based, comprehensive contraceptive information, education, and counseling to ensure informed choice. Women's contraceptive choices are made in a particular time, societal, and cultural context. Choices are complex, multifactorial, and subject to change. Decision-making for contraceptive methods usually requires the need to make trade-offs among the different methods, with advantages and disadvantages, and you often need to look at one against the other. And it really is important to sit down and discuss the contraceptives. So I was in gynae outpatients, and I saw a couple who were looking. They needed the woman had delivered with us, and she was a cardiac, and she had a complex cardiac disease, and we had suggested that she be sterilized afterwards, and she had had a normal vaginal delivery. And I spoke to her and her husband, and I explained that even if we did a laparoscope sterilization, it was still going to be her coming into the hospital, having an ECG and a new echo, and being worked up for this, and it wasn't without complications. And then we discussed male contraception and contraceptives, and he said, no, that's fine. He would go have the vasectomy. So it really paid off to have this discussion with the couple and not just with the woman. Next slide, please. So in your counseling, you have to talk about the effectiveness of the method, the correct usage of the method. So when to start it, what about missing pills if you're doing that? What about missing an injection? And then how it works, and whether they can, if you took other drugs, whether that would interfere with that. You need to discuss the side effects, the health risks and benefits of the method, and the signs and symptoms which should make the woman come back to seek medical help. The return to fertility, I think that the only ones where there's a longer return to fertility are the injectables, and all of the others have an almost immediate return to fertility. How do you discontinue the method? So if you're going to put in an IUCD, then you need to explain that the woman needs to come back if she's going to discontinue the method. And so if she may decide that she can't come back, and then this method may not be appropriate for her. And then, of course, there must always be information on STI protection. And after every method of contraception in the guideline, in the medical eligibility criteria, there's always an explanation to saying that this method cannot protect against STIs. Next slide, please. So this is, in terms of effectiveness, this is quite a useful table. And the question is whether you counsel for typical use or whether you counsel for perfect use. So it's a very comprehensive table if you look at it in the eligibility criteria, because under the fertility awareness methods, it lists all the fertility awareness methods and then gives you the typical and perfect use. So if you look at awareness methods, there's no perfect use. So your typical use is the only one. It's 24. The male and female condom now is looking at 21% failure versus and 18% for males. The difference between female and male condom is that a lot of the studies were done using male condoms. But if it is important to consider the female condom, because there are some other advantages, and one of them is also the fact that it's plastic compared to the male condom, which is a rubber condom. Then the combined oral contraceptives and the progestogen only oral pill is similar, and they are 9 for typical use and 0.3 for perfect use. Depo-Provera gets better with typical use. Then, of course, the Mirena, which is 0.2 for typical use and 0.2 for perfect use. So when you use methods that don't require the woman to be part of using it, like remembering to take the pill every day, then the typical and perfect use become very similar. Implanon, 0.05, 0.05. And female sterilization is 0.5 here and 0.5. When we counsel women, when we're doing a sterilization at the same time as a cesarean section, we counsel that the failure will be 2 out of 100. And it may be that sterilization at the time of delivery, whether you're doing it immediately afterwards or whether you're doing it with a cesarean section, may have a higher failure rate. Next slide, please. So then you've got, if you don't have a medical condition, then you really have a shopping basket. And there are certain medical conditions, and I haven't listed them, where you don't want to use a method that is not a very good method. But at the end of the day, it still is the woman's choice. So even if you've got somebody where, if you've got pulmonary hypertension from a cardiac cause and that woman falls pregnant, you would offer her termination of pregnancy, or you would suggest, you wouldn't offer, you would suggest a termination of pregnancy because that condition in pregnancy is life-threatening. So you would want to then, when you're looking at contraception, not want to use something like a barrier method, which has gotten between 18 and 20% failure rate for typical use. But at the end of the day, it still is the woman's choice. So then what I do is, once I've decided that if it's a shopping basket, then I put combined hormonal contraceptives together. So that would be the pill, it would be the patch. We don't have the vaginal ring and we don't have injectables, but those are the two that I would put together. Once I've decided on that, then I offer the woman the patch or the pill, and she can decide. There's no difference really in side effects or in the way it works or any of what we looked at in whether they choose one or the other. Then I put the progestogen only contraceptives together, and that's the pill, the injectable, the vaginal ring, or the implant. I put them all together because my counseling is the same for whichever one of those. Intrauterine methods, I put the levonorgestrel IUCD in this method, and then the copper-containing IUCD. The copper-containing IUCD, I would use the one which I think fits. Very occasionally, if it was somebody who was a paranaut or an adolescent and I needed to put in an IUCD, I may use one of the smaller copper IUCDs. And then, of course, the barrier methods and the permanent methods if they've completed their family or if they shouldn't fall pregnant again. Next slide, please. So then when we're looking at the combined hormonal methods, we don't have the injectable. The injectable uses an estrogen, which is a natural estrogen. The oral methods, I'm going to go through the oral one in a lot more detail now. And then I just decide with the patient whether they want to use the patch or they want to take the pill. There isn't much difference between that. And we don't have the vaginal ring. They've got the vaginal rings in some of the research units where they're using it for in research, but we don't have it in South Africa. Next slide, please. So then you have to decide on the estrogen. And you only have two choices. You've got ethinyl estradiol, which is a synthetic estrogen, and which is a very potent. And then you've got the estradiol valerate. And those are the two that you can choose. And the estradiol valerate is the estrogen in the pill, which is called Clara. I don't particularly want to use trade names, but it's the only way that I can explain it. And it's used mainly for women who are over the age of 40. And there's some question regarding whether you should use it there or not. And so the first thing is in terms of that estrogen. We don't use mestranol anymore, so that has come out of it completely. The next slide, please. So then you have to decide on the dose. So the one thing with hormonal contraceptive is you do not start off with the lowest dose in everybody. It is not the right thing to do. So a low dose pill by definition is one that is less than 35 micrograms. And so we never go above that. Very occasionally we would use a 50 microgram pill, and really it would be on those women who are using in drugs which induce the enzymes which metabolize both the drug and the hormone in the liver. So that would be really the only place where we would think about using the 50 microgram pill. So then it's between the other three. The one thing is in adolescents, particularly adolescents under the age of 18, you should be using a 20 or a 30 and preferably a 30 microgram pill. And the reason for that is they are in the group where they are building their bone, so the bone metabolism. So most of your calcium is deposited before the age of 18. Thereafter, another 5% or so is deposited up to the age of 24. And between the ages of 24 and 30, you have another 1%. And then another 1% is a little bit later. And that would be one of the reasons to use the 30 microgram pill. Otherwise, you could use the 20 or the 15. You don't want to use the 15 in women who have got endometriosis, or in women who have got difficulty with bleeding. So if they've got metrorrhagia, you're better off using a 30 microgram pill and go straight to a 30 microgram pill and not even look at a 20 microgram pill. So the other place where you want to continue your pills and not stop is if you've got somebody with premenstrual tension. That is the other time where it may be better. And again, you're going to use a 20 or 30 microgram pill. And then one of the other things you could do in those ones is to take out the placebo. And then they don't have the variability. The other pill which has got different doses is the triphasic pills. And those, there's no advantage to going, so it's 30, 35, and 30 in the triphasic. And there's no advantage over a monophasic. And that is just the other one where you need to look at the dose of the pill. The other one, which is the 35 microgram pill, is the one which has got cyproterone acetate. And again, to use a trade name, that's Diane. And it is because the progestogen in Diane is a problem in terms of bleeding. And that's why it's gone up to 35 so that you can control the bleeding in that particular pill. The next step in looking at the combined hormonal contraceptive, next slide, please, is which progestogen do you use? So levonorgestrel and norgestrel are the older progestogens. And if you've got somebody that's at risk for arterial thrombosis, you're better off using those ones. But it's really academic, because if you've got somebody who's at risk for arterial thrombosis, they're at risk for venous thrombosis as well. So you're really not going to use a combined hormonal contraceptive. And then the third generation progestogens, which are the Gestadine, Desogestrel, and Norgestimate. And there aren't any other advantages to using them. So it really doesn't matter. Cyproterone acetate is the one progestogen which is better for women who have got acne, who have got oily skin, and that would be the one that you would look at using there. Hirsutism, if they've got severe hirsutism, you're not going to use a pill which has only got 2 milligrams of cyproterone acetate, which is what is in there. Then you want to use much higher doses of cyproterone acetate. But once you've controlled the hirsutism, that is the pill that you could go to. Then, of course, you've got the newer progestogen, which is drospirenone. And that one is a derivative of spironolactone. And they originally looked at developing it to use with for women who have got hypertension, but you cannot give any pill to somebody with uncontrolled hypertension. So you first have to control the hypertension before you're going to use a combined hormonal contraceptive. So that is the one place. The other place that that particular pill is useful is if you've used Diane and you want to go to a lower dose, then that would be the one that you could go to. And the other one, because it is spironolactone and reduces fluid, it may be useful for women who complain of premenstrual tension. And then Dynagest is an old progestogen. It's the one which is now used for clearer. And it's a potent progestogen, and that's why they've been able to put it together with a natural estrogen. So one of the reasons that they're looking at wanting to use a natural estrogen is because of Dynagest and being able to use it. The next slide, please. The next one is to decide on the length of the cycle. So the newer pills, the ones with Gestadine, Norgestimate, and the lower dose pills are the 21-day pills. And they are where you use the active pill for 21 days, and then you have a 7-day placebo. If you go to a lower dose pill, you have to then use the placebo for fewer days, and that's actually it's 23 days of the active pill and then 4 or 5 days of the placebo. You could use the pill for 28 days or 30 days, and that would just mean taking out the placebo. And sometimes it's worth doing that if women need to control their periods for some reason, but also if they've got premenstrual tension, you might want to look at lengthening the cycle. And sorry, that is not 30 days, that's 3 months. So you could take out the placebo. So there are pills which we don't have in South Africa, which are a 3-month pill. And they've got the same amount of estrogen and progestogen for 3 months. And then you've got one which is a 12-month pill. And that is then where you don't have a period for 12 months. So it's an estrogen dose, which could be 30 micrograms, 20 micrograms, with the progestogen, and that just continues without any placebo at all. So the advantages of those ones are really just in women who have got premenstrual tension. The other advantage of that one is if you've got women who are athletes and they don't want to have their period. And the other time that you could look at it is if women are having a premenstrual migraine. And you really need to look very carefully on whether you're going to do that or not. Next slide, please. So the progestogen-only contraceptives, you know, the depomedroxyprogesterone, which could be either subcut or it could be intramuscular, and then northisterone enanthate, which the choice between the two is if you were using the injectables, the one place for northisterone would be in an adolescent. So depomedroxyprogesterone acetate is a category 2 in adolescents, and it's because of the bone deposition. The progestogen only pill is the pill that you just take all the time, and then you've got the implant. So the implant is where you would put it into the arm, and there's a way, and you need to have some training to put that in. And the implant may be, there's different progestogens, so it could be the levonorgestrel one, or the other one is etonorgestrel, and the vaginal ring, which we don't have a progestogen vaginal ring. The side effects are the same for a lot of these, and the biggest side effect of them is bleeding. Next slide, please. So then to finish off, I just want to talk about emergency contraceptives, and it's the high-dose progestogens, which may be either 750 or 1500. And it used to be where it says we need to use it up to 72 hours. But it is possible, and there's some work now that suggests that you can use it up to 96 hours. The USP regime is the 2 estrogen, progestogen pills, high dose, and then repeated in 12 hours. And we don't use those anymore, particularly if you've got the progestogens. And then the progestogen receptor modulators, and we don't have ulipristal. We've got, but we have mifepristone. We only have mifepristone in the 200 milligrams. So you would have to break the tablet if you're going to use it in the 25 or 50 milligrams. And that you would use it as a stat dose. And those you could use up to 120 hours. The IUCD, putting in an IUCD, is also 5 days, so 120 hours. The ESHRI guidelines look at using it up to 7 days after unprotected intercourse. Then, just to say that it is okay for a woman to use emergency contraceptives twice in a month. But once you've got, so it's safer to use it than not use it. Once you've got somebody who is using it more than once, then they need an alternative form of contraceptives, but it doesn't mean you can't give it. And then there's this concept of giving women emergency contraception to keep. And this is shown to reduce pregnancies and shown to be useful, and it doesn't increase promiscuity, because that's one of the things that is of concern. So it's such a big subject, and I've really just talked about those points which I thought were important. So I just want to say thank you.
Thank you very much. I really appreciate that. I'm just going to look. I don't see any questions. I'm not sure that anybody has put out questions. Perhaps while we're waiting for some other questions, I could just ask for some clarity using the slides. I was just wondering about the value in the table that you presented around failure. So basically, if I understand that correctly, you're saying that this is actually a table of failure rates, which means that female condom has a 21% failure rate, as opposed to what it should do in real life, what it should do under well-controlled circumstances. So in the real world, it's not a very effective effective method because of that typical use failure rate. Am I right?
Correct. But you see, it's no different from typical use. We're very little different. It's 18 for male condom, right? And 21 for female condom.
Yes.
And I didn't put the diaphragm here. You know, the last time I prescribed the diaphragm, I prescribed it for somebody who was going to the UK, and they were going to be able to get it in the UK. But the diaphragm in women who use it carefully and properly has got a really good typical use failure rate as well.
Okay. And so carry on. Much less than the female condom.
Less than the female condom, yes. Yes. I mean, one of the things with the diaphragm was that it was thought that the diaphragm, you know, could also reduce HIV, but it didn't show. It wasn't, you know, there was that randomized control trial which didn't show any difference in acquisition of HIV.
Right. And one other question that I thought of asking, and just the clarity around it. When you were referring to the use of the emergency contraception, you said that you wouldn't be using oral contraceptives or you know, Overall as an example any longer. What would you be advising in primary care? We are not sure that we could get the ones you're talking about, the progesterone receptor modulator. I'm not sure that this is available in primary care. So in the public service, what would you be advising as emergency contraception besides IUCD?
So I thought that they did have the high dose progestogens. So if you don't have high dose progestogens, then you could use the Overall like we used to use in the past. So I believe that the primary healthcare clinics do have mifepristone, but they've got it in the 3 tablets, which is 200 milligrams for each tablet. And I can't think whether we could break those tablets or not. The other thing is that you could take the micro-oval. You know, there's the micro-oval it's 30 micrograms in each tablet. So you could give the woman the whole, she could take all 30 tablets.
Oh, wow. Okay.
Yeah.
Okay, well, Shane Murphy, I think is on the call, says that we do have the high dose progesterone. So I think keep that in mind when you are looking around, that you do get it. Well, I don't know if there are any other questions, but I think lots of people have found this excellent and have learned lots from it. So really appreciate you taking the time out to spend, despite I'm sure your family needing you. But thank you very much. I don't know if there are any other comments or questions from the audience. If there are none, I want to say thank you. So there's one more comment. Thank you. Thank you. And let me just quickly do a quick poll. I think we didn't do that at the beginning, just to see who's around. So if you can do that, and then I see Firu is picked his hand up, so we could let me just stop the presentation so that we could quickly see who's raising their hand. Firu, let me give you the chance to speak, and if you all can just fill in the poll and let us know who's on the call, and I think that'll be quite handy for you. So please fill it in. Firu, go ahead.
Okay, thank you. So I have got an important presentation, but I have only one question, that is the relation between infertility and the repeated use of emergency contraception. Is there any relation behind that, the emergency contraception repeated use and the infertility?
You get that?
No, no, there isn't any. The difficulty with emergency contraception is, you don't really know. We know so little about it because you can't do any studies. You have to just give it. So you certainly can't randomize them. But there isn't an association with infertility and emergency contraception.
Okay,
Good.
Thank you very much.
Yeah, so none. The question also I had was that I just remembered now is the question of where you might throw away the placebo and skip periods. Does that challenge the return to fertility, or to not return fertility, but periods and then perhaps fertility? Some people are actually very concerned. Women are concerned, if I miss my periods, what implication does that have? For example, you've suggested for premenstrual tension, but that concern comes up and that questions come up. So how would you advise a person?
I want to say this, and it was a commentary in one of the journals where they talked about periods being overrated. So, but not to be facetious, but there is no problem with not getting a period. Like it used to be said that if you don't, one of the things with getting a period was that you knew that you weren't pregnant. Mm. But there isn't any other problem with not getting it, and it doesn't affect your fertility. So once you stop it, that's it. Then it's fine. You return to fertility immediately, because it's really just the half-life, and there's no storage of progestogen or estrogens in the body. Yeah.
Well, great, thank you. It looks like everyone's found it very, very helpful, and I think we're almost up to the hour. So once again, thank you all for joining us, and most of all, thank you, Professor Adam, for sharing your expertise and making this topic really simple. Thank you very much. Take care, everyone. Bye-bye.
Thanks very much, Shabir. Thank you for inviting me.
Thank you for joining.